tend to do put the guide wire first and then do the assessment mainly without fluoroscopy, because you can always find this kind of situation, a guide wire, for example, submucosal, and the only contraindication or con for this ureteral inspection is that you can have some ex vacuo hematuria. So I think it's worth doing it. We always leave a safety guide wire, especially in difficult cases. We always leave it. If we have difficult access and endopylotomies, encrusted stent, ureteral stone, of course, but we always leave it because we have used it, I think, twice in our lifetimes, but we never regret. We tend to use ureteral access sheet, yes, but not routinely, especially if there's a large stone. If we know that the stone is larger than 1 centimeter, and we're going to spend a lot of time in the OR. If infected stones, for example, we tend to use ureteral access sheet, but not routinely. If the stone is very small, less than, let's say, less than 1 centimeter, we know that the OR time is going to be very fast. Is not an infective stone, we may go without an access sheet. These are the scopes that we're using, mostly reusable scopes, the Flex XC, the V2 from Olympus, the Flex X2 that I like very much, and the Boston Scientific LithoVue as single-use scope. So we try to use single-use scopes for complicated cases, abnormal anatomy, some endoscopic combined internal surgeries, lower pulse stones that we think our reusable scopes are going to be damaged. And I really like to use my fiber optic scope in some special cases. So for example, this is a lower pulse stone that I couldn't reach with my digital scope. I switched to my fiber optic scope, and as we know that they have better deflection, I could finish the case. So I really like my fiber optic scope. Also because it's 7.5 French, it's the smallest one that we have. So it's sometimes I cannot access the ureter with the larger ones, so the digital ones. I switch to this one and I usually can get into the ureter. These are the lasers that we use. We tend to use high power lasers mainly because it gives you a little bit more of flexibility and variations between the settings. We have the TFL. I really appreciate the TFL. I'm using mainly the TFL for flexible ureteroscopy myself, but we can also use the standard 30-watt Homium laser without any problem if it's needed. For the dusting in the kidney, for the high power Homium laser or the Homium laser, I tend to use 0.3 joules, very low energy, long pulse, or any pulse modulation wanted with more or less 20 hertz. For the dusting of a soft stone, but if it's a hard stone, I tend to increase the joules up to 0.8 or 1 joule with the same frequency. I really like this frequency because I know that I can go fast. I know that if I increase my frequency, maybe there's a lot of dust that will eventually lead to me to stop the lasering, to clear out the view and then restart again. But I think this is a really good combination and a very safe combination for high power Homium lasers. For the popcorn technique, I like to increase the joules to 1.5 and the hertz up to 25 hertz, high energy, high frequency, and long pulse, as we published with Song Young a while ago. And I tend to always use these settings. And for dusting in the ureter, I always use low energy, low watts, less than 10, 12 watts for the ureter, because I want to avoid any thermal or problem or touching the ureter, then avoid any stenosis. So high power in the ureter is not recommended. I need optimal vision, low heat, so I tend to use low energy in this kind of setting. When I use my thulium fiber laser that I'm using more and more, I tend to use mostly 20, 25 watts in the kidney, 0.4 joules, 60 hertz. I really like, with always with short pulse, compared to the Homium that I always use long pulse, because the peak power is so low that that I don't want to, let's say, reduce the efficiency. We do extended indications also for flexible ureteroscopy, and we tend to do flexi in all of these kind of cases. So for PCNL, we do mainly do supine position. This is the position that we are doing, 20 degrees rotation in a Valdivia, completely supine position. Even for endoscopic combined interrenal surgery, we move the belly of the patient with this tape, and we tend to use to put the legs in for a combined position, especially for endoscopic combined surgery with bladder stones, urethral stones, and double J incrustations, for example, that you know that you're going to work a lot in the ureter. I like this position, but otherwise, if I'm only going to the kidney, supine position will be enough. So I'm going only to talk about the fluoroscopy because we're doing the 0-90 degrees puncture, which is not very widely known, but it's absolutely amazing because it's really, really fast to learn, really systematic. All our residents after their rotation know how to puncture well. Okay, in this position, in the 0-degree position, we have to choose which calyx to puncture between the upper, the mid, and the lower pole. As you can see in the presentation, the upper, the mid, or the lower pole. And then in the 90 degrees position, as you can see, we see how we rotate the kidney. We now can choose between the anterior and the posterior calyx that you can see very easily, which are anterior and which are posterior. We can say that you can see which are anterior or posterior regarding the column of the patient and the vertebra. So as you can see here, I am puncturing in the 0 degree to a middle pole. Then I see that I am very posterior in the 90 degrees position. I relocate more anteriorly my Chiba needle, and then I just puncture the kidney because I know the direction. So this is the OR setting. We're doing split screens also. We also tend to put the radiology, the fluoroscopy, the ultrasound, and the endoscopic image, everything in the same screen, in the same tower. And for endoscopic combined interrenal surgery, this is very handy. We tend to be in the side, not of the source of the X-ray, but we put the C-arm in the same side of the surgeon to avoid X-ray exposure. As you can see here, we tend to be not in the source, but in the other part of the X-ray. And we can do everything in supine position because we start with a flexible cystoscope, we remove double J's, we place the guide wires, etc. So we tend to do the papillary access. We don't like to do infundibular or pelvic access for our access. And we tend to do endovision to reduce radiation exposure when we're doing endoscopic combined intrarenal surgeries, as you can see in the picture. We always tend to place a safety guide wire. Better if this guide wire comes down the ureter, but if it's in the upper pole, it's the same. We always place a safety guide wire. This is a case that we did the entry, then we came out with the amplas sheet. I had trouble here. I was lost. I took out the amplas sheet, and thanks to having a safety guide wire, I could relocate my access without any trouble. We tend to do balloon dilations mainly. This our standard for big stones. Let's say staggering stones is it's 24 French, but for mini PCNL we tend to use 18 French. We really like 18 French because then we can do a flexible nephroscopy with our 16 French nephroscope. We use Cleopatra for very infective stones, the one that we know that there's some mucus, and we use the MIP kit with the 16 French access sometimes that we tend to do. We use low pressure systems with gravity, and I think the key of our low infective rates is that we have a good outflow. 24/5 French access, but we use 18 French nephroscopes or 18 French access with 12 French nephroscopes. A lot of liquid coming out. We use high power lasers for PCNL. We only use this kind of system for lithotripsy. More or less, these are the settings that I like. 0.2 joules, 30 hertz long pulse. This is very good for mini PCNL. You can see that here that we are very fast. If we do in a standard PCNL, we can increase to 3 joules, 4 joules, up to 15 hertz with long pulse, up to 120 watts, especially if the stone is very hard. But we can go very, very high with the power, especially because we have a good inflow and a good outflow. So the temperatures and the pressure are always low. We always end up with flexible nephroscopy to check out all the system and to remove all the fragments. And the fragments, we remove it with 3 French baskets or 4.5 French baskets that we can use with the rigid or the flexible nephroscope. We always check out the tract and we place nephrostomies if we have a big stone or a big tract. If there's no stone-free rate, if there's no stone-free rate at the end of the procedure, if we have an infected stone or there's bleeding or any perforation or complications. Otherwise, if we do a mini PCNL and there's an easy access, uncomplicated surgery with no bleeding and stone-free, we tend to do it too. And this is how we do it. Again, thank you very much for your invitation, and have a good day. Goodbye.
Okay, thank you, Dr. Emiliani. I appreciate your nice presentation to share your various endurological techniques. There is one question from audiences. From Dr. Chung-En Chong, he asked if you have any time limit for difficult RIRS to reduce the risk of postoperative urosepsis.
Yeah, so first of all, I want to thank the invitation. I'm really, really glad to be in this symposium, especially to Song Young, and I hope it can be live next time. So yes, thank you for the question. So my top for a flexible urethropscopy will be 2 hours.
2 hours.
And yeah, 2 hours. I don't exceed 2 hours. I rather do a RIRS in an hour and a half. I feel more comfortable. There's some publications saying that if you have risks as infective stones or even female patients that have or chronic ITUs or can have more infective complications, even it's wiser to do it in an hour and a half. But if I may say something, 1 hour and a half, tops 2 hours. Yeah.
Okay. Let me see. Okay, there is another question from Dr. Dong Eun An. He asked, do you inflate the balloon of Foley when exiting PCNL? I think he means the nephrostomy catheter.
Yes. I tend to place a Foley, a 12 French Foley catheter.
Mm-hmm.
I like it because it's good, it's safe, it's cheap. I just cut the tip, I put it in the pelvis, and I inflate the balloon for just 2 or 3 ml, just to fix it, let's say. Mm-hmm. It's not for bleeding. Sometimes if I have some kind of bleeding, I can do this. I can inflate for reduce the bleeding with compression, but it's mainly for fixation.
Yeah,
I like 12 French Follies because the patient has less pain than if you use a larger one, especially larger than 16, and it's a good maneuver to avoid the nephrostomy to come out. I always also put a stitch for this.
Sure, thank you. There's one more question from Dr. Takaki Inoue. during mini PCNL, do you mainly use laser system or smaller size ultrasonic laser tripter? What kind
No,
of
we only,
yeah.
yeah, thank you for the question because it's a very hot topic, I think. But we mainly use laser for PCNL, for standard and for mini PCNL, but always high power lasers. Yeah, with carefully, but always high power holmium lasers. Sorry.
Laser.
Yeah,
Oh.
high power holmium laser. Yeah.
May I ask how's your setting for energy of laser? The joule or frequency?
Yeah, for which
mini
surgery?
PCNL. Yeah.
For mini PCNL, yeah.
Yeah.
I really like, let's say, I always vary the setting, obviously, in regard of the hardness of the stone. But let's say if I have a standard 2 joules, 30 hertz, and long pulse, it's a setting that I'm very comfortable and I find myself doing a lot. 2 joules, 30 hertz, and long pulse.
Oh.
You can see you can rapidly treat 3 centimeter stone, for example. Uric acid stone, it's great to treat like this. Soft stones, but even hard stones, you can increase a little bit the energy or modify a little bit the frequency, but this is a standard setting. It's a great setting.
Okay, the next question is, in case of complicated stegon stones, do you still use a laser system or you consider using ultrasonic or pneumatic stripper?
Yeah, so in the same line, thank you for the question. We still use laser, high power holmium laser for complicated stagger. So if I may say, we use 2 lasers because we tend to do endoscopic combined intrarenal surgery. So I use high power holmium laser again, but remember that you can increase if you have a good outflow in this regard, we use a 24 French axis with an 18 French nephroscope. So we have a lot of outflow. So we reduce the temperatures at minimum and the pressures. So we tend to use high power holmium lasers up to 120 watts. So we can set the laser from 2 joules to 4 joules or even more, and more than 30 hertz to go very, very, very fast. And I think holmium laser, it's very good for PCNL also. Yeah, there's a lot of evidence saying that it's comparable to ultrasonic and other lithotripsy devices. And if you see it in your practice, it's as fast as they are.
Okay, thank you. There's still several more questions, but because of a time limit, I think we need to close this session here. I thank you, Dr. Milani, again, and thank you all of our audiences. We will move to the next session. Thank you.
Thank you very much for the invitation. Bye.
Thank you, moderators. And yeah, we have more than 15-minute delay. We have to move to the next session, and I want to introduce 2 moderators, Professor Chong Sung-wen and Professor Ujin Pang. So maybe I already introduced Professor Chong Sung-wen, and Professor Ujin Pang is the associate professor in the Sacred Heart Hospital, Department of Urology, Halim University College of Medicine. He is the Secretary General of the OSCET meeting. So would you take the next session? Okay, thank you.
Thank you very much. Just moving along to the second session, we have some nice speakers lined up for us. The next speaker, Professor Choi Wei-jin, who is a good friend of mine. He's one of the earlier adopters of the thulium laser in Singapore. He comes from the National University Hospital, and he trained in the Bristol Urology Institute. And his main interest is in endourology, and he's also a leading trialist in the Resume and the Urolift devices for the lower tract. But for today, he's going to tell us his experience of the thulium versus the holmium in RIRS. Professor Chua.
Yeah, thanks, Dr. Chong for the kind introduction, and thanks to the organizing committee for allowing me to share with you my experience with the thulium fiber laser. I'm just going to share my screen now. Right, so for the next 15 minutes, I'll talk about the thulium fiber lasers versus the Holmium laser in retrograde intrarenal surgery. So I'll divide my talk into four main components. First, I talk about the fundamentals of laser. Then we talk in details the difference between Holmium, YAG, and the thulium fiber laser, and the consideration when choosing a laser for RRS surgery. And I'll end off with our experience with the assaultive thulium fiber laser. So the term laser is an abbreviation of light amplification by stimulated emission of radiation. So laser is a device that stimulates atoms or molecules to emit light at a particular wavelength and amplify that light, typically producing a very narrow beam of radiation. It differs from other sources of light in that it emits light which is coherent, and this allows a laser to be focused to a tight spot, and the laser beam can stay narrow over a great distance. I think for many of us, I think we're familiar with the use of laser in our clinical practice. We use the KTP green light laser for BPH treatment. We use the CO2 laser for treatment of penile warts. So for the Holmium YAG laser, it has been the gold standard for laser for stone treatment over the last 20 years. It can effectively fragment any stone composition and can also be used for soft tissue ablation, tumor resection, and the measurement of stricture. As majority of this laser energy is absorbed by water, it is very safe to be used in an aqueous environment. The earlier laser machine can only manipulate the pulse energy and frequency. However, with the increasing use of the current high-power Holmium YAG laser, they're capable of attaining higher pulse energy and pulse frequency, and this allows user to control pulse duration, and this also allows user to control pulse duration and pulse shape. The low pulse energy and high frequency allow dusting of stone to fine fragments, which are able to be evacuated spontaneously, obviating the need for time-consuming retrieval of larger stone fragments. So the ability to control the pulse duration and the shape also reduces the stone retropulsion, which is an important consideration when we are doing RRS surgeries. An example with the Moses technology by Luminous, the delivery of short, low energy pulse to create a vapor bubble before delivering the actual ablative energy pulse reduces the stone retropulsion. So the Holmium YAG laser has been doing well for the last 20 years and has been a commanding pole position in stone surgery. It's only until 2020 where the new super pulse thulium fiber laser system for urinary stone was launched in the US. And this new laser offers several advantages over Holmium laser that may expand the boundary of laser lithotripsy. So is this going to be the game changer? So the next session, I'll just look into details and compare the two lasers. The Holmium YAG laser, the construction of Holmium YAG laser require a flash lamp powered by a high voltage power supply that inject light into this laser crystal containing Holmium ions. This laser crystal then emit photons at the desired Holmium wavelength of 2001 nanometers. This laser radiation then travel back and forth between two reflective mirrors located at each end of the cavity to be formed into a straight collimated laser beam. And this laser beam must then be focused through a system of lenses to fit into the small coils of the surgical laser fiber to be delivered to its final target. So there are two kinds of Holmium YAG generator that we are familiar with. The first kind, the low power generator. However, it has limitation. The maximum energy that it can generate is up to 2 joules, and the maximum frequency is only up to 15 hertz. In order to obtain higher frequency, to obtain fine stone dusting, a few of this laser cavity has to be combined together, as seen in the newer generation high power laser, to generate frequency up to 80 to 100 hertz. And why are we doing that? Okay, next I talk about the thulium fiber laser. The thulium fiber laser, on the other hand, uses several simple laser diode as an energy light source instead of the flash lamp. The gain medium producing the 1940 nanometer thulium fiber laser beam is a simple and very long thulium ion containing active fiber with a very thin fiber core. And because this laser beam originates inside this small fiber core, the thulium fiber laser beam can be directly coupled to and delivered through another attachable laser fiber to carry the beam to its target. And the thulium fiber laser uses electronically modulated laser diode, and as such, a comprehensive range of laser lithotripter parameters are available for adjustment. The pulse frequency, we can adjust it up to 2200 hertz, and the pulse energy can go down as low as 0.025 joules. Such low energies are important when performing dusting procedure, as it can help to obtain the smallest dust particle possible and to keep retropulsion to a minimum. So the key difference between the two lasers really are the two main difference is actually the maximum pulse frequency and the pulse energy range. The maximum pulse frequency for your 120 hertz or 120 watts Homer laser is 120 hertz, whereas that of the thulium fiber laser is up to 2000 hertz. Likewise, you can see that the lowest pulse energy range from the Homer laser is only 0.2, whereas for the thulium fiber laser, it can go down as low as 0.025. And the other main difference between the two machines is that is the power supply. The Homer laser requires dedicated high amperage power outlet, whereas the thulium fiber laser, it can be used from any standard socket in the operating room. These two slides basically give us a visual view of the two machines. As you can see from here, the Homer Yak 120 watts system is quite big and bulky laser. It's large and heavy, and this is because it uses the water-cooled system. Whereas in the thulium fiber laser, you can see that it only is much smaller, lighter, and because it uses air-cooled system to cool down its the heating element. And in addition, the Homer Yak laser rely on a complex series of mirrors to align laser energy into a single beam. And these mirrors are to be critically aligned and are sensitive to any movement of any component. And as such, regular maintenance and repair are necessary. In comparison, the thulium coil lasers are confined inside the fiber with no mirrors, leading to a much more robust system design with less maintenance. So what are the consideration when choosing laser for RRS? I think for me, there are four main components that I look at. One, the particular size. Two, the ablation rate. Three, the retropulsion. And fourthly, the safety profile of the laser. First, let's talk about the particular size. The ability to dust urinary stones without the need to remove residual fragments has been recognized as a highly desired features of a lithotripter. Stone dust are defined as particles small enough to spontaneously float under 40 cm water irrigation pressure. The mean settlement time should be more than 2 seconds through a 10 centimeter saline solution. And importantly, in today's context, it should be suitable for aspiration through a 3.6 French working channel. The thulium fiber laser produces 3 to 4 times more dust than that of the high-powered frequency Homer laser at similar power level. And likewise, it produces more small dust particle under 0.5 mm, regardless of the stone composition. So this result was presented in AUA 2019 by Dr. Ben Chiu and group. Dr. Ben Chiu is a prominent urologist in Canada, and he has been involved in many of the stone study. And in particular, he was one of the first few surgeons who were experienced with the superpulse thulium fiber laser. As you can see from his presentation slide, there were more dust that being created using the thulium fiber as compared with the 120 watts holmium yak laser. And likewise, there were fewer large fragments found at the end of the procedure. Next, the ablation rates. As you can see from the same group who had done this similar study and are presented in WCE 2018, I may show that the dusting ablation rate for the same average power comparing the two machines, the thulium laser fiber is consistently faster than that of the 120 watts holmium laser. And what the reason for the high efficiency for the thulium fiber laser is a better water absorption at 1940 nanometer compared with the 2001 wavelength. I think the other important factor is the symmetrical pulse profile with uniform energy distribution and constant peak power with the thulium fiber laser, and also the lower retropulsion rate. This is just another study that was done by the Stone group from Canada. You can see that using the thulium fiber laser, the retropulsion is significantly lower. I think what is the most important aspect when considering with the consideration of getting the laser machine is the safety profile. And thulium fiber laser has been demonstrated to be a safe alternative to that of a holmium yak laser. The reduced retropulsion and consequent reduced medium turbulence result in better endoscopic view. However, there is a concern that with a higher water absorption of the thulium fiber laser may lead to a higher temperature rise and thus thermal damage. And the same group have actually looked into this aspect of safety as well. What they have done is that using an ex vivo porcelain ureter, they measure the temperature using the thermocouple, and the average maximum temperature, as you can see in this table here, there's no significant difference in temperature increase in comparing the holmium yak laser when using the same pulse frequency and energy setting as that of the thulium fiber. I think what is important when we talk about temperature safety in RRS is that constant irrigation, use of core irrigation fluid, and intermittent laser activation can mitigate thermal effects and avoid unnecessary damage to the surrounding tissue. As the irrigation rate reduces, even low power setting can produce significant temperature increase. Therefore, special precaution has to be taken when fragmenting obstructing stone in the ureter, as potentially dangerous intra-ureter temperature has been documented. So the general recommendation is to avoid laser setting above 10 watts in the ureter. So back to my original question. So what are things that I consider when choosing the laser fiber if I have to get one for my department or my unit? So comparing the two machines, I think both machines are equally effective, although we know that for the Saltiv or for the thulium fiber, you can have the frequency range that goes slightly higher, up to 2002. In terms of the power energy wise, I think both are equally good in terms of pulse energy. What is main consideration for many of the center worldwide is the current requirement for the holmium yak laser, the 120 watts. It requires a higher energy pulse compared with that of the thulium fiber laser, which can plug into any of the wall socket. So in many of the older operating theater, you may not have the facility of a higher M socket, and as such, many of the center or many hospitals are now moving towards getting a smaller machine that can plug conveniently to any of the wall socket. So in NUH, I think we bought the thulium fiber laser for the above consideration, and we started using this laser from 13th of August last year. And Basically, this is just to show you, let's to cut off the sound. This is just our experience with this low power laser. Sorry, this is just our experience with the tubular fiber laser. It's a big improvement compared with the low power Holmium laser that we had before that. I think the main advantage we can see from this laser is the faster ablation rate, smaller particular size, as well as the reduce in the OR time. And this also allows us to do more RRS surgery and to start our mini PCNL program. This is just the specification of the tubular fiber laser that we bought. As you can see, the laser energy can go as low as 0.25, and the laser frequency can go as high as 2004. And this is the wavelength. I think the big advantage is being a small laser. It can be plugged in any of the wall socket and can move it between ORs. I mean, this laser comes with 5 different laser fibers ranging from 150 micron to 940. And for RRS surgery, I typically chose the 200 micron, although we can use the 150 or the 200 micron. And for the mini PCNL, you can either choose the 365 or the 550 microns. So for those who are thinking of using this laser, I would suggest starting with the default laser setting and then adjust the setting according to your experience. And also, once you are more comfortable with it, you can adjust it based on your needs and also the stone hardness and the stone type. There are many different laser settings has been presented at various conferences. The ideal one has not been established. My initial setting will be to a fragmentation using 1 joule, 20 hertz. And for my dusting setting will be 0.2 joule, 100 hertz. Dr. Ben Chiu, I think he just tweaked recently. For his setting, he would like to try fragmentation with a 0.6 hertz, 0.6 joule, 60 hertz. And for his dusting setting, 0.15 joule at 300 hertz. So just some take-home messages. What tubular fiber laser technology brings to urology is that it is more efficient at stone breaking with increased dusting capability. It's a wide range of setting available for the highest level of procedural flexibility. It's a longer pulse width, higher frequency, a lower pulse energy. And the lower pulse and a lower pulse energy, the longer pulse and the lower pulse energy contribute to less retropulsion. And the more uniform beam coming out from the laser are also more easily aligned with the smaller diameter, more flexible fibers. And as such, we are able to use it with a 150 micron laser. So with this, I will end my talk here and happy to take questions during the question and answer session. Thank you.
Thank you, Prof. Chua. In the interest of time, we'll move on. So all this talk about dusting, how are you going to get it out? So the next talk is going to tell us about suction devices, and we have Dr. Vinit. Dr. Vinit comes from the Sri Ramachandran Medical College, and then he trained further at Strasbourg and finally ended up in Singapore with the Ng Teng Fong General Hospital. And he's quite a well-known speaker in this area, and we look forward to his very interesting talk on suction devices in RIRS. Go ahead, Vinit. You're muted, Vinit.
Okay, I'm been pressing unmute. Am I audible now?
Yes.
Okay, thank you. All right. So once again, thanks for the kind introduction. And my topic has been suction in RIRS, something which all of us know about, and sometimes we wonder, is it really useful? So, well, these are my conflicts of interest, but no financial interest over here. And I can tell you that I personally think it's a game changer. And if you ask me whether I'll use suction in RIRS, the answer is 100% yes. What you need to understand is how I've also understood is what do I do with the suction? Why do I want the suction and how do I use it? Basically, suction in urology, what exactly is this? Whatever you're doing right now, be it VCNL, RIRS, ECRS, just add suction to it. And voila, you have a suction in endourology mode. But why now? And I think all the talks have really alluded to what I'm showing you. We have all these options which have evolved in the last 2 decades. We are in the era of high power lasers and more powerful lasers. We are in the era of miniaturization. We are in the era of using a tailored approach. And whether it's PCNL or RIRS, we really have moved to using better energy devices. Now that's key because that's helped us to miniaturize surgery. I mean, we've always evolved and we've been evolving to make surgery access smaller. And whether it's PCNL or whether it's RIRS, we are trying to get into a mode where we can actually give the patient a better experience without making an unnecessary morbidity of the procedure. So with that, I think it's time for change. With miniaturization, we've all wanted to go smaller, not only in the cell phones, but also in our approach to endourology. RIRS really has helped us to tackle bigger stones with experience, and PCNL is making us tackle bigger stones with smaller holes or smaller access. Why? I think the four main concerns in miniaturization, first we need to address is removing all the fragments, maintaining intrarenal pressure, keeping the intracalyceal temperature low, maintaining vision, and sepsis. If you can tackle these are the what's that we really need to handle. And if you can do that, we can actually access a very good surgery in a very short period of time by using a very small access. So the more important question is how. I think the basic point of fragment removal in RIRS was either we used to blast and extract, where we use whatever device and then take it off with a pneumatic or ultrasonic laser and then take it out with the basket. And the baskets really went through a big evolution and we have different baskets. However, now we are dusting. We are dusting more. So we wanted to either come out by actively washing it out, where we use a lot of hand pump devices. Otherwise, we leave it passively to gain out with gravity. But why not you use suction and aspiration? And there's evidence in literature which shows that dusting is good. It says that when fragments are small, it helps to spontaneous passage in 3 months. And you need a laser with pulse modulation that has been shown both by Professor Chua as well as Dr. Esteban. And it's non-inferior to extraction. And I think there's enough evidence. We know that you can be a duster or a buster, as Dr. Ghani alludes to. And it both are right. There's no wrong. But the problem is when you have dust, and what exactly is dust? When we look at the Tenon definition of dust, they mean particles less than 250 microns, right? Because that's what it floats. If you look over here, it's floating over here, and you need to get that removed from the system. Otherwise, it will stay inside the system. It may again get fixed together and form stones. So that's the whole idea. When you have a high power system giving you so much more dust, for example, Moses, or even if it's a TFL, which tells you that it gives you twice as much dust, what do you do with all that dust in the system? Do you just let it be? For example, you look at it in your own practice. I'm sure you would have seen this. There's so much of dust, which are either, I use both. So a holmium laser is showing you all this. And if you look at the TFL laser, you look at this also gives you so much of dust. It's great to see so much dust in the system, but what are the problems of dust? It can cause snowstorm effect. It hides the bigger pieces behind. It obscures your vision. When you are going continuously, you've got to keep stopping to removing the dust. Larger stones, that can be problematic. Well, your definition of larger stone may be 1 centimeter. My definition may be 3 centimeters. It's not the problem. The problem is when you have a lot of dust, it can be problematic. And then it settles in all those dependent calyces and funny anatomies, and you're really struggling. How the hell should I get this out? So maybe we have a solution there now. So, and the solution to that is for different stones, you have to apply different strokes. And a little bit of a different stroke is use suction. And I use suction in 3 ways. I'm going to show you some which is already standardized and traditionally available, some which I think is new in literature, and something which we are still experimentally studying. So we use the access sheet. We have something new, which is called the bendable access sheet, and then we use suction via the flexible ureteroscope itself. So a quick run through without taking much time. The evolution of the suction access sheet is basically, it tells you 3 things. It's safe, it reduces the risk of retropulsion, and it definitely reduces intraluminal pressure. We keep talking about this, so everybody has done the studies in the development of an access sheet, and they tell you the same story in all the papers, no matter what, that if you have a high intrarenal pressure, you can have pilovenous, pilolymphatic, pilotubular reflux, and you can have sepsis, and you can have damage to the calyceal system. And the only easy or the best way is put an access sheet. You put an access sheet, it reduces the pressure. So if you're going to reduce the pressure by using a ureteric access sheet, why not add suction to it? It will reduce the pressure more. And I think there's evidence, much more evidence. The same happens with temperature. When you use these higher lasers, you have a lot of heat inside. I'm sure some of you would have kept your hand in front of the irrigation fluid and realized it's hot. So when it's hot, you don't want the temperature to be transmitted. But fortunately, by keeping an access sheet, we maintain a safe range of temperature, as we know by evidence as well. So with all this available, we have now clearly shown that by active suction, that means whatever you're doing through your suction sheet, you add suction to it. This brings down the temperature inside. This brings down the pressure inside much more than just a conventional access sheet. And that's why suction has a big bone. So they've invented suction platforms. Many papers have now come which show you machines which have integrated all these. And I won't go into details. And this is a very intelligent suction-based platform which gives you pressure, temperature, suction, etc., etc. So with all these, let's come to the main core of what we're going to be discussing today. And let me talk you through the first thing, which is the suction by access sheet. What exactly do we do here? We put an access sheet, we put a scope inside, we use whatever laser we want to use to break it. Earlier we used to put a basket, but now we go back over there and then you suck it out through the access sheet. And then when you suck it out through the access sheet, you find all the fragments which are coming out and you can empty the system. Now, typically this is how I do. I only sit down and do RIRS. So I put in an access sheet exactly the same way as a normal access sheet. But what is important to tell you here is please anchor this access sheet. For example, if you're doing RIRS on the right side, anchor it on the right side. On the left side is a practical tip, because when you add suction through this tube over here, it really creates a lot of vibrational effect in the sheet. And if it's anchored, the sheet stays stable, it doesn't move in and out. You will not cause inadvertent trauma. So fix the UA sheet on the ipsilateral side. It's a practical tip that I would suggest to most people who are learning. Next, what do I do? Irrespective of what scope I want to use, as you can see over here, you have to use your finger to control the suction. And you use it intermittently. Don't use it continuously. You see what happens when you have that snowstorm effect over here. As I can see, I'm using a good laser to really dust. I'm intermittently sucking. And by intermittently sucking, if you observe the screen over here, it gets clearer because the dust is going. I can see my surface, which I'm constantly touching in the stone. It may not be so much over here, but look at this one. Here, I'm really using a high power laser. I know people always wonder, should we use a high power or should we just stick to low power? We are talking about high frequency, okay? If I'm using a high frequency laser and then I add suction, because it was so much of a snowstorming, you suddenly see the vision gets so much clearer here. You look at that, it's much clearer. And this is something you need to see because you need to see all the stones. So that's basically the principle of using an access sheet. And you have different access sheets. My favorite right now is a Cleopatra. It may change, but at this point of time, I think it's good. But the reason I like it, it's good because another very critical practical point is you need to have an access sheet with a stiff body, but a soft tip. Your access sheet has to go in and out. It's not going to be sitting just below the PUJ. It needs to move in and out of the access system, because if you keep it just below the PUJ, when you suck, gets closed. So I keep the access sheet beyond the PUJ, make sure that, so that's my key home, move it inside across the PUJ. When you want to move it, you want to keep a guide wire, you don't want to keep a guide wire, that's your personal preference, but you must have a good hydrophilic coating. And so far I found this to be one of the better access sheets. And then the next thing, which I promised to tell you, was about a bendable access sheet. So what happens here is, if you can't go into, you can't get all the stones from different parts of the calyces because it's really difficult to suck out lower pole, etc. So why not innovate? Why not you make an access sheet which can go everywhere? So in this access sheet, what we've done is we bent the tip of the access sheet. And when I say we, I mean, really thank Saeed. A lot of you know Saeed bin Hamri, who's really doing a lot of good work on this. So when you have a totally flexible, bendable suction access sheet, as you can see over here, this access sheet can easily go into all the calyces. Yes, it's slightly longer from your conventional access sheet, but what we are principally doing over here is that you break the stone with a laser, as you typically do. Normally, we would suck it out. So what we are doing over here is you take your access sheet, you can go into the upper pole, you can go into the middle pole. I go straight up to the stone, I put suction to it, and I can aspirate the stone. This suction access sheet can actually go into different parts of the kidney as long as you have a good infundibulum. If you have a very narrow infundibulum, sometimes it can be challenging. So everything, there are pros and cons. Everywhere there are, limitations to all surgeries. But it's amazing because 95% of the times you can get away. So it's one of those systems where you don't have a good access to a stone because of a narrow infundibulum. Maybe you don't want to consider RIRS, you want to consider ECRS over there. But what it's doing now is making the bigger stones easily accessible to RIRS because you're confident of removing the particles. As you see over here, I'm sucking out the fragments, and these are not dust fragments alone. You can see they are slightly bigger fragments. And as they are coming out of the access sheet, I find that, okay, now I need to take the axis sheet to these parts. So I use my scope as a guide, and I bend the axis sheet with the scope tip inside, as you will see shortly. And I suck out all the fragments over here. And by doing that, the entire chamber, there you go, everything is clear, all that is clear. So I take my axis sheet over there, I use my scope as a guide, I take the scope into that calyx, now I enter over here, there are fragments here, again, take your axis sheet over there, withdraw the scope a bit, apply the suction, all the fragments come out, and you're able to completely clear most of these stones, I'm almost zero. Potential advantages of these obviously are that you can clear everything under vision, right? That's the biggest advantage you want. Now, I said sometimes you have a smaller infundibulum, you have a narrow ostium, and you can't go there. But your scope usually allows you to. So what we did is we took it, instead of taking the sheet to the fragments, we went one step ahead, and we thought, why not we take the scope and add suction to the scope? So what we did over here is, and this is all part of some multi-center studies that I've been part of and we've done, instead of using the suction in a scope, in a sheet, we've used it, attached it to a scope. It's a very simple innovation which we did. We connected two three-way adapters. One is for irrigation and one is for suction. Now we connected that to the scope. And I would really, really have to thank Dr. Salim in India, who's the pioneer of this, introduced me to this, and I'm quite a fan of it now, having used it. Yes, you may say that it's a bit crude because, you know, you have to keep opening, closing. Good news for those people who think that this is a bit crude. We have moved on to the next model and the next model after that too. So in step by step, just like Apple iPhones, we'll be releasing them. We are still just finished the clinical studies, about 150 patients. I'll share some data on that. So here, through the scope, you can aspirate. What's key is by using the same principles of irrigation and suction, we are able to take the scope into different parts. Now, you want to keep an axis sheet or not is up to you. It's not mandatory in this. We find that the key is actually to get dust. And to get dust, I think maybe the Moses and the TFL is a better option than a conventional laser. But having said that, you can still do low power laser lithotripsy. It may just be a little more time consuming. But you really need dust, not particles, because the scope channel is small. So you don't want the particles to get stuck over there. So we found that by doing that, as I'll show you over here, there's no axis sheet. I've taken the scope over there, and now I'm just sucking out everything from the pelvis. And as I suck out everything in the pelvis, I'm advancing the scope across the PUJ. Sometimes it comes into the proximal ureter. I'm going, there you go, across. You can see the PUJ, how it's opening, closing. So that's why I said, if you're using an axis sheet, you must move it into, but here, no axis sheet. We're just advancing the scope inside. Now I've gone across the PUJ into the pelvis. And then I again suck out all the stones, all the dust, sorry, in the various pelvic calyceal systems that we see. And once I've cleared all that, almost everything gets clear. And so you really need dust because the smaller fragments don't come out. So when I see dust in my plate, which I open up in the machine and I find this kind of a picture, I'm very happy because I know I've really done a good job and I've cleared all the stones and fragments. So here we are bringing the scope to the fragments. So that's how we've changed. So suction in RIRS can be done through an axis sheet, which is being done almost everywhere in the world. Via the scope itself in selected centers, we've introduced it. And not only that, if you, let's say, cannot use this and whatever your limitations are, you can still do aspiration post-lithotripsy. And that's a great invention by Professor Glenn Preminger and being studied by Professor Stewart, who they call it the Shure system, where you can actually navigate. It's just something like your Ryle's tube or something like your suction catheter, which you use when you want to, after your anesthesia. So you introduce this, but this is steerable. That means you can actually, under fluoroscopy guidance, take it to the different calyces and suck it up. I have no personal experience in using this, but I have personal experience in seeing how it's being used. It was used in a very big center in India, and well, they claim that the outcomes are really good. The initial papers do show that they can achieve 100% stone-free rate. It will definitely add to your fluoroscopy time, so something that you keep in mind. Now, all these are ways in which you can use, but the innovation continues, and this is again something which I'm privy to. We have the Sotron ureteroscopy, where at the tip, they modified the ureteroscope a bit, and you can actually have a suction option available directly to your ureteroscope. And the next generation after this, some of you may have seen Richard Wolf has come out with, where they made the tip completely flexible. So innovations are constantly happening to introduce suction in the ureteroscopy, because I think that is the way forward. Not only just RIRS, it's also coming in the PCNL. You have different kinds of handpieces which are being available where you can add suction. And basically what suction is telling you is that it's removing all the fragments as you do the laser lithotripsy or just after you do the laser lithotripsy. And the outcomes are fantastic. So I think the world is moving forward. This is my personal interpretation of how suction and endourology is going to be in a couple of years from today. This is something which we just completed a multi-center audit. I just wanted to show with you two important points. The anesthesia is commonly used as general anesthesia, but it can be done under spinal anesthesia. The scope suctions, we find that the patients are very comfortable because there's no access sheet in the penis. The spinal anesthesia works very well. There's no hard and fast rule. You can use whatever scope you have available. The more important point is using a good laser system. Definitely would recommend for a holmium more than 30 watts and thulium for in case you need really fine dust. Again, the operative times are slightly longer if you're using the suction in the scope. We hope to improvise that by using the newer suction in scope modality which is coming out. Well, probably next ETS meeting, maybe we can get a chance to talk about that. What is important is there are no complications. Okay, there is absolutely no bleeding. There's no major Clavian grade 1 or 2. Patients who had fever, and we realized they were all infective stones when we look back. So suction works very well, very good for having infective stones. And we didn't have too many residual fragments, which are less than 4 millimeter. They're only 2 millimeter fragments. And at the end of 3 months, when you look at a CT scan, you find that the stone-free rate is really, really good in a single stage. And I think the key is the single stage. So we've also compared that with PCNL. We're still studying that a little more, but we find that it's equally effective. Of course, PCNL is a slightly bigger access and a better modality to take away the bigger stones. But I think what I would like to say in this, that my observation was that by adding suction, I'm able to actually tackle the bigger stones more than 15 millimeters. If you take stone volume wise, they are the 2000 cc stones, the harder stones as well, the keys as well as PCNL. So that's something which we want to hope to change, where we can tackle the bigger stones with the suction and RIRS. And I presume, like everything changes, these were the guidelines in 2012 where there was no talk about RIRS at all. And hopefully in 2023, for all we may find there's some papers which talk about the role of suction in endourology. So having said that, the world of endoluminal endourology, we're having an ETS meeting today. So in the era of the advanced endoluminal endourology, as some of you would know, the term was coined by Darren Smith. Everything is changing and we have to change. We have to think forward. Why we need to think forward is because so far, if you look at all the stones, I mean, this is personally, but I'm sure all of you are doing the same thing. We've actually miniaturized and we've reduced the number of tracks. So today we can use any of these options. So why not just add suction to it? And if you're doing RIRS, it's the same. We counsel for ECRS, at least I do for all my patients, but I choose on the table based on how the dynamic look of the pelvic calyceal system is on RPG. If the calyceal system is friendly, I don't mind trying RIRS. If the calyceal system is not friendly, I suggest better move to PCNL. Reduce the size of track, don't have to go in for a bigger track. You can always jump from a smaller track to a bigger one. What we're trying to tell you here, or what I'm trying to say, is that you need to personalize your treatment. You need to move to the way of personalized stone approach. ECRS, I think, is a great way to do that. And what suction and endourology, if you ask me, take-home messages, does it matter now? My answer is yes. Is it totally new? No, but it's evolving. Is this practically feasible? 100% yes. How does it really help me? It has helped me to improve the outcomes. It has helped me, or I'm learning better to improve the stone-free rate, and definitely minimizes my complications. My patients are able to go home the same day more confidently. Lesser stents are being placed. So something which we are trying to study and learn. I think the key points are that it helps to improve the vision, pressures, temperatures, and stone-free rates. Where I find its biggest use will be bigger stones. It will definitely reduce the need for post-op imaging. It will definitely reduce the need for stents. I think it's minimizing complications, so that's good. And maybe it will help to reduce the tracks, and a good alternative for stones for PCNL as well. So thank you. Until we have another big trial, prospective one, I think it's early days, but definitely promising days. Thank you very much.
Thank you, Vinit. Many questions for you, but we have to move on. I'll leave it to Professor Wu to introduce the next speaker.
Once again, welcome everyone to the first 2022 ETS Symposium. I'm Ujin Bang from Hallym University. Next topic is ESWL update, position, respiration, shockwave, etc. The presentation will be given by Dr. Min-Soo Chu and Song-Yong Cho. Professor Min-Soo Chu was graduated from Seoul National University Hospital and is currently an associate professor at Seoul National University Borame Medical Center. He is an expert in BPH study and AI machine learning. Professor Song-Yong Cho, I think he need no further introduction. Please welcome Professor Chu and Cho. Please.
Thank you for your introduction. And today I'll introduce cavitation in the therapeutic ultrasound and laser. And then Dr. Min-Soo Chu will tell you how we can understand the therapeutic effect on the target and the protocol of ESWL. As a clinician, I have studied how laser and therapeutic ultrasound work on urinary calculi for several years, and I have published the results in a Springer book and some SGI journals. So I want to share some basic information that would be good to be aware of even as a clinician. Cavitation or cavitation bubble is at the center of my information about the laser and the therapeutic ultrasound. And you can see the summarized contents published this month in the Investigational and Clinical Urology Journal. To compare the effect of focused ultrasound, let me talk about the mechanism of stone fragmentation by laser device as a good example. In the case of laser, stones can be fragmented by mechanisms such as photothermal ablation, photoacoustic ablation, and thermomechanical ablation. And thermomechanical ablation is related to explosive vaporization and to maximize energy transfer to the water, and it explodes in the intercrystalline spaces or pores of the stones. Now I'll talk about one millisecond worth of cavitation bubbles. Everything happens in this 1 millisecond. So the shock waves induced by laser emission in the short pulse mode were maintained for about 1.1 or to 1.2 millisecond, and repetitive laser emissions generated multiple laser-induced cavitation bubbles. The bubbles seem to be helpful in breaking the stones by producing ejectile forces, and cavitation played a critical role in stone dusting and energy delivery. So this laser-induced cavitation bubbles normally occur 0.005 millisecond after laser emission and expands till about 0.6 millisecond. They usually rupture for the first time at about 0.8 to 1.0 millisecond, according to the pulse shape and the laser transmission. The longitudinal diameters parallel to the laser direction were about 6.8, 8.6, and 9.6 millimeter at the laser powers of 1, 2, and 3 joule respectively. And you can see that Lagena-shaped bubbles were found, and the maximum size of the bubbles reached 9 millimeter. Pulse shape technology, you can hear about Moses, and this is the pulse shaping technology, and it demonstrated a higher stone fragmentation efficacy with less retroposion and better targeting than the conventional single mode short or long pulse direction. So the figure A is showing that we already reviewed the cavitation with an energy of 2 joule in the short pulse mode, right? And let me talk about the long pulse and the figure B. So the long pulse showed the similar pattern, but we can see the additional Lagena-shaped bubble at about 0.6 millisecond with continuous laser emission. That's the long pulse mode. And figure C is showing that when at about the Moses, the technology, and when the Moses contact and distance modes are compared, the initial bubble maintained for about 0.650 to 0.8 millisecond respectively. So the initial big bubble was the largest size in the short pulse mode and the smallest in the Moses mode, although the transmitted total energy was the same. That was the point that I was surprised to see. So main difference across these 3 modes, short pulse, long pulse, and Moses distance mode was the continuity and the peak power of the laser beam. So long pulse, the important thing for surgeon is we have to recognize that long pulse mode is not appropriate to break hard stones, especially when you see the hot part of the stones in the core, right? So because it's a low peak power, the long pulse is not so good to break the hard stones. The interrupted laser beam of the Moses mode generated a high peak power, and the multiple separated groups of bubbles ruptured at about 0.8 and 1.1 millisecond. So for pop dusting technique, as a clinician, we have to know that we have to use the short pulse mode or the Moses mode. How about the cavitation bubbles in the ESWL treatment? The original ESWL machine was an electrohydraulic lithotripter, and as technology progressed, novel machines were invented, including piezoelectric and electromagnetic lithotripters. A single shock wave normally transmits destructive energy from cavitation bubbles for about 0.6 millisecond, a little bit different from laser-induced cavitation. And the size of the bubbles was only about 2 millimeters, and numerous bubbles were found within the focal zone around the stone or target. The shape of the bubbles were almost round. You can see the figure, and the water jet can be found when they rupture. So the water jet consequently destroy the targets, stones or tissue. So the shock waves in ESWL carry energy with changes in water pressure and create many bubbles at the same time. The problem is the cavitations from the generator of shock waves make the clusters of the damage in the phantom gales mimicking the renal kidney tissues. It can damage the renal tissue together with the stone. This acoustic cavitation in this slide can show the patterns of the micro damage in human kidneys. And as you know, the focused cavitation can cause subcapsular hematoma or tissue damage right after ESWL procedures. According to my VR simulation program and the in vitro experiment, the hit rates to the stone, were only 11.3 to 12.2% without respiration adjustment when the stone size was 10 millimeters. In vitro experiment showed that, unfortunately, the hit rate ranged from 50 to 67% in the respiration electromotive device setting, but actually the hit rate seems to be not so accurate, because if the stones move, then we thought, okay, we can imagine the stones were hit by the shock waves. So with the slow breathing, as the hit rate went down, the percentage of remaining large particles went up. So you can see the graph of the hit rates. So the VR simulation program was only 11 to 12%, but fortunately, the hit rates can be elevated to around 50%, although it is not so accurate to think. So we are challenging a new device to maximize the efficiency of ESWL regarding respiration. And I think the respiration adjusted ESWL is very important to be developed to increase the hit rates and stone fragmentation efficiency in the near future. And just Dr. Mr. Chu will introduce some ESWL technique and the mechanisms to break the stones.
Nice to meet you. I'm Mr. Chu, working in Brahman Medical Center, which is located in southern Seoul. This time, first, I will introduce one simple technique that can improve the outcomes of ESWL, especially for the distal ureteral stones, and then introduce the latest and highly promising technological innovation using new shock waves in ESWL. The most important factor for a successful ESWL procedure is appropriate patient selection. Fortunately, however, we urologists have control over some device-specific technical factors that can affect the ultimate treatment outcome. Patient positioning is one of the most important factors in ESWL, especially for the lower ureteral stones. To avoid the bony pelvis surrounding the distal ureter, The supine position ESWL was proposed in the 1990s and has been recognized as an effective and safe method. However, prone patients suffer from discomfort, increased the intra-abdominal pressure, and reduced lung capacity. Therefore, some urologists have moved back their attention to supine position that can target through a gap in the pelvic bone, such as a sciatic foramen. We confirmed that the supine transgluteal approach was associated with more effective stone fragmentation and clearance than the conventional prone transventral approach. In addition, the supine transgluteal approach showed higher overall satisfaction and a low complication rate. The mechanisms of stone fragmentation in ESWL procedure are described in the following 5 theories. In order to more effectively transfer these physical stresses, various technological developments are being attempted. Among them, I would like to introduce burst wave lithotripsy, which could be a game changer regarding the future role of ESWL. Burst WL is an alternative non-invasive method using ultrasound pulses rather than shock waves. The primary difference between the two modes of treatment is the pressure waveform being applied to the stone. SWL applied shock waves, which are a broadband wave with a single high amplitude compressive pulse followed by a tensile tail. In contrast, burst WL applied a narrowband burst, a lower amplitude sinusoidal pressure pulse in such a way that an opera singer can share a wine glass with her voice. The difference in the pulse output leads to substantially different effects on the stone. A key characteristic of this method is that the size of fragments generated when the stone integrates is controlled by ultrasound frequency. In this way, the technique can be tuned to create small fragments that can pass naturally and potentially improve the success rate of a lithotripsy procedure. Burst WL formed several fractures simultaneously, most prominent near the front of the stone, leading to small fragments separating from the main stone body. In a porcine model, burst WL has been identified as an effective and safe technology. The first study of burst WL in 19 human subjects resulted in a median of 90% comminution of the total stone volume in fragments less than 2 millimeters and 10 minutes of burst wave exposure with only mild tissue injury. In summary, cavitation bubbles of AC and LIC should be regarded as energy and the mediator of energy for stone fragmentation and tissue destruction in the urological field. New technologies are challenging in the area of therapeutics ultrasound. If recent technological developments such as burst ESWL will be integrated in new devices, there could be a renaissance of ESWL in clinical use. Thank you very much for your attention.
Yeah, thank you, Professor Cho and Chu. Last topic is a recent update of mini HOLAB, new lasers and surgeons live. Dr. Felipe Figueiredo is a Brazilian endourologist of Pompeia Hospital. He is the developer of MI Lab, minimally invasive laser enucleation of the prostate using smaller resectoscope. Please welcome Dr. Felipe Figueiredo.
Hello. Let me share my screen. 1 minute. Hello, can you see me?
Yes.
So, good afternoon, everybody. Good morning here. It's 4 a.m. in Brazil, but I'm really happy to be here with you today. So I'm going to speak about advances in many HOLEP, new lasers and surgeons' lives. I work in Pompeii Hospital. Currently, I have an exclusive BPH practice doing slim HOLEPs and ultra slim HOLEPs, and I'd like to share my perspective about the subject today with you. So right now we have a plethora of BPH treatments. We have old players and new players. But the long-term outcomes that we have, it's from TURP, enucleation, and vaporization. I have this in front of my screen. 1 minute. Okay, right on. So during the 20th century, TURP was considered the gold standard for BPH treatment because it's cheap, it's reproducible, you avoid abdominal incisions, but it has many limitations. We have complications like post-TURP syndrome, especially in monopolar TURP. We have bleeding. We have adenoma regrowth that compromise durability of the obstruction. And we have urethral strictures after urethral trauma. One of the limitations is the gland size. You can do a good TURP up to 80 grams. That's recommended by the guidelines. And over that, you leave a lot of residual adenoma that may compromise durability. The average resection efficiency is 0.5 grams per minute. And this is related to the size of the loop. We usually use a 26 French sheath, a continuous flow that has a 24 French loop, and you can't downsize the loop without compromising the efficiency. So we came with the HOLEP and endoscopic enucleation that have been proposed as the new gold standard because it's size independent. We have level 1 evidence from many randomized clinical trials. We have series with up to 18 years of follow-up showing its durability. You can perform it in anticoagulated patients, and it's cost-effective and recommended by our main guidelines. We have this famous editorial from Thomas Herman that is nucleation is enucleation is enucleation, but does it really mean that every kind of enucleation is exactly the same? From my perspective, no. If you read the editorial, not only the title, Thomas explained that surgical technique is more important than the energy source, but the instrument size and the energy source are still important. The biggest problems of endoscopic enucleations are transient stress urinary incontinence and strictures, because patients may feel worse than pre-op. BPH is a benign condition, so the patient has very low tolerance for complications. Transient incontinence is something especially common during the learning curve. Once you master the anatomy and you perform the dissection respecting the sphincter, you can fix this problem. But strictures can happen even after a very, very experienced surgeon. It's related to the surgical time because the time you spend inside of the urethra with your scope may generate ischemia in the urethra. And with the learning curve, you can reduce your surgical time and improve this factor. But the instrument size is the other variable that we can modify to reduce the incidence of the urethral trauma. Peter Gilling and most of enucleators perform HOLEP and endoscopic enucleation with the same 26 French sheath of TURP. But laser endoscopic enucleation don't need a 24 French loop. So if we analyze the urethra anatomy, it has two narrow parts, the subnavicular urethra and the bulbous membrane of the urethra. And sometimes they don't fit the 26 French sheath. at the tip of the resectoscope, we have these elevated steps that sometimes it's one of the major source of trauma during the introduction of the resectoscope. So the first option to advance the scope through these small parts is to try to adjust the urethra to the instrument. So the first way is to use a metallic dilator to dilate the subnavicular urethra. But with this kind of dilation, you may generate a circumferential trauma and a circumferential scar. So usually the meatus is the submeatal stenosis is the most common stenosis after transurethral prostate surgery. The second option is to use an Otis urethrotomy to perform a linear incision in the urethra, increasing the diameter of the lumen and creating just a linear scar that will prevent the circumferential scar formation that will generate the stricture. This randomized clinical trial from South Korea a few years ago have compared the Otis dilation with no dilation before HoLEP. And they have found that using Otis prevented 100% of the stricture in this small cohort of patients. And in the group of no dilation, 6% of the patients have developed the strictures. Otis might be one of the options to prevent it. But if you don't have Otis available, in Brazil, we don't have Otis in most of the hospitals. I have one, but I have bought at the AUA meeting. I have never seen an Otis in Brazil before. So this is a small trick that may fix the problem. First, you check the caliber of the meatus with this conic dilator. Then you use a level scalpel blade to perform a dorsal meatotomy using the scalpel. And then you check the meatus again, and it may increase in 2 to 4 French with this simple maneuver. But what about the membranous urethra? Should we dilate? Should we incise the membranous urethra sphincter with the Otis? Probably this is unsafe and it may generate stricture. The other problem of the resectoscope is the holes in the outer sheath. During the friction of the resectoscope, you have this grater effect in a reference of a vegetable grater. And the urethra and the sphincter may be injured by this grater effect. So the second option is to adjust the instrument to the urethra. So if you do bipolar laser, bipolar enucleation, BiPolep, the two available probes from Olympus and from stores are only available for the 26 French sheath. So you cannot downsize the bipolar probe yet in 2022. If you do GreenLab, you use a large side fire fiber and you can use the 26 French sheath, but Richard Wolf has the 24 French sheath available for GreenLab. So it's possible to perform green laser nucleation with a smaller sheath. But with HoLEP and TULIP, you use a very tiny fiber. It's 0.55 millimeters, 550 micron. So you really don't need the 26 French sheath to be able to pass such fiber, and neither a 24 French sheath, although they are the most commonly used. You can use a 22 French sheath and even an 18 French sheath. So a few years ago, maybe 5 years ago, I have performed my first slim HoLEP. I used this 22 French resectoscope. It's basically the same resectoscope of the 26. But it's 22 French. It's smaller. It's continuous flow, rotatable, and it uses smaller optics it's 2.9 millimeter. The standard cystoscope is 4 millimeter. Originally, this is an hysteroscope to be used by gynecology to look at the uterus, but this company from Germany have developed the laser working element, and we can perform HOLE perfectly with this scope and treat process of any size because it has an excellent flow. Another modification that I have requested was a new obturator that fit directly the outer sheet. So we have only one step to reduce trauma during the introduction. And I asked them to increase the number of holes and to put smaller holes to avoid the greater effect. And it's amazing, really amazing, the new sheet. They also have this 18 French ultra slim resectoscope. That's what I use in most of my case today. All prostate with less than 80 grams, I perform the ultra slim HOLE. And if it's larger, 200 grams, 250, I use the 22 French sheet. I don't use 26 French in any prostate anymore. I have an extra long resectoscope, is 6 centimeters longer, that I use for patients with rigid penile prosthesis and very, very large glands, like more than 300 grams. But I barely use it because it's larger, but sometimes I have to use, if I have to use this extra long resectoscope, I put a Foley 1 week before to pre-stent the urethra and generate a dilation of the urethra. It works the same as a double J in the ureter before an urethral access sheet. So if you check these images, you will understand what I say. The amount of trauma that you induce using these smaller sheets, it's much less, and this will reflect in the symptoms after surgery. Patients has no urethral complaints, and with HOLEP, you remove the catheter in less than 24 hours. Patients are discharged at homes, and more than 50% of my patients don't get any analgesic pill in the first week after sling HOLEP. But how to morcellate? Usually we use the same outer sheet of the 26 French resectoscope to adapt a long nephroscope from the Storr system. But Richard Wolf has the 24 French morcelloscope that can be used with their outer sheet. We have developed with RZ the Slim morcelloscope project, which would be a fiber optic morcelloscope to reduce the size of the optical system and have more space for inflow and for the working channel. And it's brand new. It fits directly the outer sheet of the 22 French resectoscope. And as you can see, you have the fiber optical system, the lights. We have a 5 millimeter channel and 2 large irrigation channels. It's very important to have good inflow to overcome the powerful aspiration of the morcellator. And the inflow is excellent. We have published 2 months ago in Urology Video Journal, a video and a paper describing the technique. It's not only the scopes, but the way we perform it to improve vision, especially with the ultra slim, that we don't have too much flow. And it's an en bloc approach with early optical release. We have described our modification of Dr. O from Seoul National University, is the curtain opening incision. We have adapted for the en bloc. It's open access, and I would enjoy if anyone would like to see it. So we created this concept of MILEP, minimally invasive laser enucleation of the prostate, using the slim and ultra slim resectoscope. It's not only for HOLEP, it can be used with thulium fiber laser, thulium YAG, as long as a 550 micron fiber. And what's new about Holmium lasers? Holmium is a short distance laser. The laser beam interacts with the irrigation, the water of the irrigation, and you decrease the energy delivered at every distance that you are from the fiber tip. So if you are in less than 1 millimeter, you have a cutting effect. You boil the tissue and you vaporize the tissue. If you have more than 3 millimeter, all the energy have been spent on the water, and you have no thermal damage, only the mechanical damage of the shock wave of the bubble. But between 1 and 2 millimeter, you have the coagulation effect. And this is the ideal distance to work during HOLEP. Now we have the pulse modulation. It was proposed initially by Luminis with the MOSES technology. It's actually 2 pulses very close to each other. And Quanta system from Italy also has the same concept of the virtual basket with double pulse. The idea is that you can reach further, you have a longer reach and allow an easier coagulation because you can coagulate from slightly more distance. So it's easier to keep the correct coagulation distance if you use the double pulse. And Quanta has the same concept. It's a short pulse and then a long pulse that passes through the bubble. But there are different pulse modulations, not only the double bubble. You have the vapor tunnel that allows a better coagulation, the virtual basket, and the key wave bubble blast that has more mechanical displacement. But how can you use it for HOLEP? So I really enjoy this feature of the Quanta laser. It's called the master pulse technology. Actually, you can set up 7 different pulse durations during your surgery. With the shortest pulse, it's only 50 microseconds. You have a very high peak power. You have a bigger bubble and a more shock wave, more infiltration of the plane. It helps to identify the correct anatomical plane, and you have this spreading scissor effect. As the bubble expands, you detach the adenoma from the capsule like a dissection with a scissor. The bubble opens the plane. And in this short video, you can see that you create tension with the tip of the sheath, and the bubble completes the detachment of the adenoma. But most of this enucleation has no coagulation because you are working too distant from the tissue. This is what happened with short pulse during HOLEP, especially with the 26 French sheath, because you are further from the tissue. If you use the longest pulse duration, you have a much longer 1,100 microseconds. You have a lower peak power, a smaller bubble, less shock wave, but better coagulation and more vaporization. So this is the vapor tunnel that we have seen before. It's a very long bubble, and it's great for hemostasis at the end of the surgery. For me, the best way to perform HOLEP is the no-touch technique. You are always working between 1 and 2 millimeter. It's a laser-assisted blunt enucleation. The tension is created by the tip of the resectoscope and to create traction, and the bubble finishes the enucleation, but you coagulate simultaneously during the enucleation. So you don't have to come back to search for the vessels. It's easier to keep the plane, avoid you to leave a residual adenoma or to have a capsular penetration, and you have excellent hemostasis. For me, this is the Columbus egg of HOLEP and allow the enucleation coagulation at the same time. My equipment is the Quanta laser. We have 2 pedals. In the left pedal, I use more energy and a short pulse duration if I want to open the plane. But most of the surgery is performed with 1.2 joules and a medium-long pulse duration. So with less energy, I have better coagulation, and I work a little closer to the tissue, especially with the smaller sheets. And what about surgeon's life after HOLEP? This is a poster from AWA 2011, and it describes a tertiary German center describing the number and type of BPH surgery in their hospital. It was a 10-year follow-up comparing open surgery in blue, TURP in green, and HOLEP in red. And in 2005, they started doing HOLEP. And what they have seen is a dramatic reduction of TURP and open surgery, and an increase in total number of BPH surgery, because once you start doing HOLEP, large processes start to come from everywhere. And this is what I have seen in my practice too. The other thing is that the world population is growing. The expectation is that it will increase even more, and the life expectancy is also increasing. So the number of patients needing BPH surgery is increasing. In 2021, I have changed my private clinic to the Enlarged Prostate Institute, and it became an exclusive BPH practice. Most of my cases, 99% are MILEPs using 18 or 22 French. I only use the 26 if I need to use the extra long resectoscope. And I'm doing 6 to 10 HOLEPs per week. For me, this is my dream job. I expect to do HOLEP for the next 20 years until I retire. And I'm happy to be sharing with you my daily practice here today. Thank you very much. This is my contact. If anybody needs anything about MILEP or HOLEP, it will be my pleasure to help. I have a YouTube channel too, and I met most of my friends here from Twitter. I try to avoid looking too much, but I use it almost every day. Thank you very much.
Thank you, all the speakers, for the wonderful talk. Especially thank you for Dr. Dr. Felipe Figueiredo. I think you are staying up the all night, very difficult time. Yeah. We will have a panel discussion on the topics. 3 renowned experts joined us as a panels. First, Professor Oh Sung-kwon. Oh Sung-kwon was graduated from Seoul National University and is currently an assistant professor at Hallym University Gangnam Sacred Heart Hospital. He is an expert in robotic surgery and endoscopic stone treatment. Next, Professor Won-ho Chung. Won-ho Chung was graduated from Gaemyeong University and is currently an associate professor at the Gaemyeong University Dongsan Hospital. He is an expert in minimal invasive stone surgery and medical device development. Next is Dr. Min Tung-do. Min Tung-do is a urologist at Viet Chek Hospital in Haiphong and Vietnam. He is currently PhD student in urology in Seoul National University. Are there any questions, panels? Any question, panel?
Okay. I have a question for the Dr. Chawei in first lecture, and thank you for the nice lecture. I've seen some reports about the thulium laser in the stone surgery, and from 2019 there are many articles about the thulium is better than the holmium laser because the small fiber, and we can have great vision, and scope deflection is better, and safety profile is better, and the machine is small and convenient. So I can think the thulium may be an alternative to holmium laser, and sometimes the thulium can replace the holmium. Do you think? I want to know your thought. But currently many centers use the holmium laser. So what do you think is the reason for the use of holmium? And is there any advantage for the holmium laser?
Yeah, thanks for the excellent question. Yes, I agree with you. Since the most recent publication shows that thulium fiber laser has been probably a new game changer for the fact that it is smaller in size. It doesn't require a high power socket, and in terms of efficacy wise, this if as good as that of the chromium jet laser. The reason why chromium jet laser is still very popular today is because it has over the last 20 years evolved a lot. Starting from a low power laser, has moved on to a high power laser, and there's various variation. And one of the latest one, which we have discussed today, is that of the Moses technology. And if you ask me why is it that chromium is still very popular, I think the main reason is that because it's in the market the longest, whereas thulium fiber laser has only been in the market since 2020, and it has only been marketed for sale, I think, start from 2020 and 2021. So you don't see that many thulium fiber laser available worldwide. This is something that I have been considering for my unit when we was looking to buy our high power laser. We're considering between the two units. That's why we took a special interest in studying the difference between the two and to analyze the safety profile, the efficacy, as well as the practicability. So in older hospitals like ours, whereby most of the operating theaters do not have high power socket, it's a lot easier for us to use a machine that's more portable. In the event that one OR is being used, I can actually move the laser to another OR without having to shift the operating case out to another OT. So that is probably one of the considerations when we're looking to purchase the machine. Yeah, I hope that this answers your question.
Thank you. Yeah, I have a question to Professor Min Soo Cho in Korea. Actually, in Vietnam, in my hospital, I think that the ESW is disappearing. And in my hospital, urologists think that the ESW is a very boring procedure. And it usually is done by the technician nurse. And so I think that this is the reason why in my hospital, the effectiveness of the ESW is very low. So I would like to know about the situation of ESWL in Korea and what is the trend of ESWL in Korea.
We anticipated ESWL will decrease according to the increase of surgical procedures, but according to the data, in Korea, the ESWL didn't decrease. Actually, it maintained. So, and I believe that the ESWL can be performed under local anesthesia in Korea. Of course, in some countries, ESWL is doing as being performed under general anesthesia, but local anesthesia is okay in Korea, and many people think that the procedure time is very short. It needs only 30 or to 40 minutes. So I don't think it'll disappear, but the proportion, of course, I cannot anticipate the actual number of the proportion, but I think it has a very strong advantage for the patients and the physicians as well. But well, let me see the future in the near future about the proportion of the ESW. A new technology will increase the efficiency, so maybe it will not disappear.
And I have a question for Dr. Felipe Figueiredo. In large prostate patient, I still hesitate to whole lab surgery because modulation is a very stressful procedure. So do you have know-how about effective modulation?
Hello. So morcellation is actually an automatic process. You must have a good morcellator. There are many available in the market. The first morcellator was the VersaCut, and it's not very effective. We have a lot of hard nodules we call beach balls, and sometimes it's time consuming. But the new oscillating morcellators like Piranha from Richard Wolff and the Hawk morcellator from China, it's much more effective, and we don't have too many beach balls. So morcellation efficiency is more related with the morcellators. The morcescope I have shown that is compatible with the 22 French sheet. It has a 5mm working channel. It works with all the available morcellators in the market. I have tried with VersaCut, with Piranha. That is my favorite. I use in a daily basis. But I have tried with the Hawk, and it works perfectly. You have no major issue because the inflow, the irrigation of this morcescope is perfect. It's better than the 24 French from Wolff. I have all available resectoscopes in the market, and the inflow is as good as the stores, and it's better than the Wolff morcescope. So I have some tips and tricks to avoid emptying the bladder that may happen if you have a very aggressive aspiration. Sometimes you have to stop to allow the bladder to fill. But if the opening of the window of the blade is closed by the tissue, you don't have too much fluid aspiration. So morcellation efficiency is basically the same. You won't compromise the efficiency because of the smaller scope. Concerning the enucleation, using the 22 French is the same efficiency of the 26, but the 18 French, it takes 20% longer than the 22 French. So I only use it for small glands, which are fast operations. But I think the greatest device is the 22 French resectoscope because it allows you to do everything, enucleate, morcellate with minimal urethral trauma. But some urethras, some membranous urethra don't fit the 22 French sheet. So using the 18, you do the enucleation, all the movements, you have less trauma. And when you go to morcellation, the urethra is already dilated by the 18 French resectoscope. So you can pass the 22 French with less trauma.
There are many interesting questions received by Zoom. Professor Bennett, what urethral exercise is suitable when doing suction during RIRS? And what suction pressure setting do you use in RIRS? And do you worry about damaging your URS working channel by suctioning through it? Would you do this with a reusable URS? Many questions.
Thank you. Before I take my question, Felipe, that was an awesome talk, as always. Regarding the suction, the first thing is suction within the scope doesn't damage the scope. It's just sucking. You're not, even if you could put a laser through that and do laser fragmentation, there's no reason suction can damage the scope. I've only used the fiber optic scopes with a TFL laser for all the suction scopes for about 100+ cases. Where we studied in that center, there was no damage. I've used the suction and scope for 5 different reusable and 1 disposable, 1 digital scope. Not had a problem with any of them. It hasn't caused any blockage or damage. Like I said, but you can only suck powder. So I make sure that I have powder or really, really small dust over there. Regarding the other question, the suction pressure, I have learned by default to keep it at the lowest. So keep the suction lowest because you want a uniform suction pressure throughout, because you remember, as you're sucking the fluid, the water irrigation has to be increased. So I typically use Atraxia flow. Normally, I used to use 80 to 90 pressure, but now for suction, I increase the pressure to 110, 120. So the flow rate is increased because you're having more water going out. But I still don't use more than a 3-liter bag. and it can be done under spinal anesthesia, general anesthesia. Both are fine. With respiration control is ideal. The advantage of suction is purely to remove the fragments. Again, if you're using irrigation access sheet, this is to answer Professor Takaki's question. They don't make them less than 1113. When I spoke to the company, it's the way the suction access sheet has been designed to have the channel for the suction. You can't have it less than that. Having said that, there is a company which is looking at making it smaller in the 9.5, 11.5. It's the inner diameter which they are finding it a challenge to make it smaller, not the outer diameter. Obviously, when you have a suction access sheet, it is a little more rigid compared to your softer sheets. The reason being that when you apply that suction through that channel, the suction access sheet actually tends to collapse. So again, they cannot restrict the diameter or change the material, but that was completely changed when we made the bendable access sheet. So the bendable access sheet prototype, I'm sure we'll see it released soon, but it's still under study. Saeed has probably completed all the cases, and then hopefully we get to use it again. And I don't see any problem using any reusable or scope. There's been no damage so far.
Because of time limitation, we will have one more question from Zoom. Dr. Philip, in your practice, have you seen a significant difference in stricture rate with the slim scopes? Stricture rate? Yeah.
Yes, actually, as I have said in the presentation, first I had the smaller resectoscope. So the nucleation was performed with the smaller sheath. But for morcellation, I had to change to the 26 French sheath again to perform the morcellation. So many of the benefit I would lose during morcellation because I had to pass the 26 French in the end. Even then, you reduce the time of distension of the urethra and you have less trauma. But since I started using the 22 French morsoscope, I haven't had any case of stricture. We are talking about 350 cases since I started using the 22 French morsoscope. So my rate is right now 0 in the last few years. It's very comfortable for me to finish the surgery and tell the patient that he will be fine. He won't have this kind of complication anymore. And I see many people saying that they don't see too many strictures after HOLEP or after TURP, but in the literature, we have 2 to 4% if you use 26 French sheath. I think it's too much. I'm doing 6 to 10 HOLEPs per week. 5% is one patient with a stricture every month in my office, and this is too much. If you can reduce this to 0, it's more benefit than mini PCNL and PCNL in transfusion rates, because macro PCNL has 2% transfusion, 1% transfusion, and we are downsizing it, increasing surgical time in PCNL, increasing intravenous pressure to reduce 1 or 2% of transfusion. And why not reduce this 2 to 4% of stricture using smaller scopes? So this is something that I believe it will push laser nucleation forward. We have a very slow adoption because it was described in 1998, but now with the internet, with organized urological societies like what you are doing right now, the knowledge is much more widespread, and we have more and more people able to teach. I'm teaching a friend from Australia in complete online mentoring, and he's doing an amazing job right now. And if I have to do my HOLEP, I would do with him because he already has the smaller scopes.
Thank you. It's been a wonderful discussion. Thank you again, speaker, panels, and our audience. I think we all enjoyed listening to those great work and presentation for our last ETS meeting 2022. I again appreciate you all being here and your participation today. Finally, let's hear the closing remark of ETS 2022. OSET President, Professor Cho. please.
Thank you. Finally, we had a wonderful another event today, and I really enjoyed our conversation and discussions. And all the speakers and the audience, thank you all for your precious time sharing your experience with all of us. I hope you stay healthy and safe, and maybe next year we can meet in person in an offline ETS meeting. So yeah, please stay safe. Thank you all. Thank you. Bye.